This is the case presentation of Aaron with Ethan Hahn, Sam Hunter, Sophia Burge, Vishant Palanivel, and Teresa Vasquez. Aaron is a 21-year-old single college student and the only child of two parents. He has had a history of sociability before college and no history of romantic partners. His case study did not indicate any family or personal psychiatric history. After Aaron moved away to college, he began to perceive his face as hideously ugly. One day, he looked in the mirror and thought his ears were too large, that he had a crooked nose, and that his eyes were different shapes. So he started what is known as camouflaging, where he constantly wore a hat over his ears and sunglasses in order to hide his face. He also reported repeatedly body checking, where if he was near a mirror, he had to constantly look at it, as well as habitually touch his face. He also doesn't believe anyone if they tell him he isn't ugly, and has convinced himself that everyone is just lying to him or being nice. This has also caused Aaron increased feelings of anxiety and depression and is causing him to be much more antisocial. Aaron sought out a referral for a plastic surgeon, but his doctor suggested a therapy appointment instead. Aaron does not believe he needs therapy and just wants the therapist to write a report that supports his request for plastic surgery.
Aaron can be diagnosed with body dysmorphic disorder as he qualifies for the DSM-5 criteria, and his symptoms do not qualify for an eating disorder like anorexia nervosa. He exhibits a preoccupation with perceived flaws in his face that his friends, family, and doctor cannot see. He actively performs repetitive behaviors in response, namely mirror checking. His preoccupation causes impairment in his social functioning as he isolates himself, maintaining his skewed beliefs. He shows completely absent insight, believing that the fact that he is unsightly is irrefutably true and that he requires plastic surgery as a result. Body dysmorphic disorder is defined by an individual becoming obsessed with the belief that they have defects in their physical appearance when these defects are either imagined or greatly exaggerated. It is an obsessive compulsive related disorder in which the obsessions and compulsions are purely physical, often manifested in appearance checking. Individuals with body dysmorphic disorder most often focus on facial features such as wrinkles, skin spots, swelling of the face, a misshapen nose, jaw, or eyebrow. Others worry about other body parts such as their feet, hands, or breasts. They often limit contact with others and attempt to conceal their defects, such as using sunglasses like Aaron did in the example. BDD is relatively common, occurring in 0.7 to 2.4% of the population, and generally develops in adolescence with no gender bias between males and females. Approximately 50% of individuals with BDD will seek plastic surgery, 80% have suicidal thoughts, and 25% will attempt suicide at some point in their life. Causes of BDD are unknown, but generally considered to be a combination of social and genetic factors.
It is likely that Aaron's disorder began due to a combination of biological, social, and psychological factors, with the biggest shift being in his social environment. Aaron started to experience symptoms of BDD as he entered college. His old social life was comfortable. He had friends, he participated in school, he played sports, he had a good community around him. But when college started, Aaron was put into a new social environment, one that he is not as comfortable with compared to his old one. Aaron also had difficulty making friends at college, unable to connect with his roommates and others around him. Due to this, Aaron lacked a solid support system and strong interpersonal relationships in his new environment. His new social environment caused him to feel isolated and alone. Aaron also had a low self-esteem for himself. He does not feel confident in his appearance and is struggling to be accepting of it. During high school, he reports being shy, indicating that maybe he experiences low confidence in himself as well. Aaron says he began to feel agitated and angry during college because of his experiences. This could suggest the potential for Aaron to have low temperament, thus playing a further role in how he perceives his new environment and himself. Although there is no confirmation of this, a low temperament could be attributed to Aaron's genetic makeup. Since Aaron says he sometimes feels depressed, angry, and overexpressive, he seems to be struggling with mood regulation. A biological reason for the development of BDD is neurotransmitter dysregulation, specifically with serotonin. If Aaron does have neurotransmitter dysregulation, this would also explain his irregular moods along with his other BDD symptoms. All these factors in combination with each other led to the development of BDD within Aaron. In terms of maintenance, Aaron holds negative core beliefs about his appearance and how others perceive him. These core beliefs cause him to experience the world through a biased lens, producing automatic thoughts such as mind reading, jumping to conclusions, and more. Overall, this causes him to maintain a mental filter, only taking in information that he chooses. This is especially harmful because he refuses to accept anything that his family, therapist, or friends say about his normal appearance, thus maintaining his core beliefs even more. He can't challenge his core beliefs this way if he's not going to acknowledge the opinions or the facts that others give him. Due to his intense fixation on his appearance, he also constantly checks himself in the mirror whenever he gets the chance, touching his face to often confirm to himself that he is deformed. This behavior maintains his core beliefs because he's reinforcing the idea that something is wrong with how he looks. Since he believes his appearance is off-putting, he often camouflages, avoids his roommates, and isolates himself from others. He wants to go unseen and not expose himself to what he believes is a harsh world with people that are disgusted by him. This negatively reinforces his core beliefs because once again, he is not giving himself an opportunity to challenge these core beliefs. All in all, Aaron's behaviors directly and indirectly keep up his core beliefs. In order to help Aaron, we need to shift them to ones that are rooted in reality.
Now that we've finished Aaron's case conceptualization, we can focus on his treatment plan. First, Aaron must receive his diagnosis and begin therapy. Getting him to engage in therapy will likely require initial motivational interviewing. Once Aaron begins to recognize that body dysmorphic disorder is severely limiting his life, it's our recommendation that he begins cognitive behavioral therapy. If CBT is ineffective, an alternative treatment is acceptance and commitment therapy, or ACT.
Perhaps one of the most important steps to take even before engaging in treatment is to make Aaron aware of his BDD by helping him recognize that something is not quite right with his own perception of self, which can help him transition from being ambivalent to treatment to foregoing cosmetic surgery as a solution after learning about the symptoms of BDD. This can be done through motivational interviewing. By gently guiding Aaron to consider therapy, Aaron is better posed to being able to come up with a self-centered plan that can get him accommodated to the benefits of treatment and by helping him feel validated and understood.
Following motivational interviewing, it would be appropriate for Aaron to begin cognitive behavioral therapy, the most common treatment for body dysmorphic disorder. Although CBT used in the treatment of body dysmorphic disorder is similar to what is used in the treatment of obsessive compulsive disorder and other disorders, it is important to note that special attention must be placed on the lack of insight, delusions of reference, and unique impairment that many people with body dysmorphic disorder face. For this reason, treatment of BDD is expected to take significantly longer than disorders like OCD and MDD. Several manuals have been created that guide practitioners in the use of CBT for body dysmorphic disorder. These guides typically focus on psychoeducation, cognitive restructuring, exposure and ritual prevention, and perceptual retraining. In Aaron's case, we will focus on exposure and ritual prevention. The first step in exposure and ritual prevention is creating a fear hierarchy. Typically, social situations in which the patient with body dysmorphic disorder cannot cover their features receive the highest SUDS, or selective units of distress, scores. Aaron will therefore begin by creating a fear hierarchy, rating situations that promote the least to the most anxiety. A simplified version of Aaron's potential fear hierarchy is shown on this slide. It indicates that Aaron will experience the least distress when he was sitting at home alone without a hat and glasses, and he will experience the most distress when he is in a large crowd or group of friends without a hat and glasses. After writing down Aaron's fear hierarchy and SUD scores, we would start with the in vivo exposure of spending time alone without a hat and sunglasses, and eventually progress to taking the hat off in front of a therapist, attending social gatherings, etc., as we work through the fear hierarchy. As Aaron completes each step of the hierarchy, it is important that he does not engage in rituals like checking himself in the mirror or asking his friends and family for reassurance. Although these negatively reinforcing rituals reduce Aaron's anxiety about his appearance in the short run, they only maintain his disorder in the long run. It is important to stop this cycle in order to help Aaron live a more fulfilling life. Working through this fear hierarchy will also encourage habituation and cognitive restructuring as Aaron learns that he is capable of being in social situations and that people are not as focused on him as he thinks.
By treating Aaron using ACT, there can be a cognitive diffusion in favor of a values-based approach and recognizing that his thoughts are just thoughts. ACT provides the opportunity to increase Aaron's willingness to engage in activities despite difficult emotions that can arise. For instance, by sticking through negative thoughts and attempting to simulate emotional acceptance and living according to his values. For example, he wants to have a social life while in college. Aaron can further target his body image distortions. Through ACT, Aaron can also have a chance at reforming his control strategies in an adaptive manner through acceptance, moving towards committed action that is centered around leading an adaptive, values-based lifestyle instead of maladaptive behavior that ignites his current desire for cosmetic surgery. Additionally, given the associations occurring in BDD, in Aaron's case, he has to realize that the language he uses to describe himself only accentuates his suffering. As a result, according to research studies, ACT and CBT methods can be meshed together to teach clients to recognize that their own language and cognitions can create suffering even without external stimuli. Specifically, no one is telling Aaron that he is ugly. No one else comments on his appearance in the same way he does to himself. And realistically, no one is thinking what he is thinking to the extremity he is. And yet he continues to feel extreme distress and dysfunction. Overall, ACT aims to focus on a client's values of committing to a rich life, and in this case, not focusing on a lifestyle centered on appearance. ACT may in turn help decrease dropout problems that can be experienced with traditional exposure methods through helping a client learn how to deal with negative emotions through willingness to commit to activities despite any challenging emotions.
It's important to reiterate that Aaron's treatment will not come without challenges. Aaron is beginning his treatment with no therapeutic agenda and a strong desire for cosmetic surgery. Although this may seem difficult to overcome, a clinician may begin conversation with Aaron by discussing cosmetic surgery more with Aaron. This is one way for the clinician to begin to develop rapport with Aaron. From here, motivational interviewing can help Aaron begin to identify that his negative self-image is hindering his life and well-being, which will make him more likely to engage in therapy.
There are potential challenges that can arise with a values-based approach in ACT. Based on the cultural environment with which Aaron lives in, there may be goals and values he holds that he may have been told are adaptive, but if they confirm his maladaptive cognitions, then there is a potential issue of exacerbating his body image dissatisfaction. However, these challenges can be overcome through treatment by helping him realize that his extremely negative perception of himself is exaggerated and untrue for all the people that surround him. He is not actually such a hideous person. And this concludes our presentation.